Good afternoon, everyone. Thank you all for coming. Um, I have this technology since the last 2 years, but I wasn't using this modality, that is autofluorescence, till Dr. Nitin Prabhudesai asked me to speak on this, and I'm very grateful to him for that, so that I could start using this tool in my day-to-day practice, and I'll share my brief experience with this. So this is about autofluorescence, ultra-wide field autofluorescence imaging. So basically, it's a non-invasive in vivo imaging modality, which gives us a lot of information about the cellular metabolic. This it gives us mainly about the retinal pigment epithelium. And the Optomap AF uses a green wavelength of 532 nanometers. So the basic principle is that we use fluorophores, which are naturally present in the retinal pigment epithelium. And what fluorophore means is that it absorbs light of a particular wavelength and emits light of a different wavelength, which is picked up by the camera, and we generate the autofluorescence images. And so lipofuscin is the most dominant macular fluorophore, and it's increased in degenerative disorders like AMD, macular dystrophies, and other conditions. So what are the indications of autofluorescence imaging? It's basically drug toxicity, optic disc drusen, chronic CSR, choroidal nevus versus melanoma, heretomacular dystrophies, and AMD. So I'll just show you a few case examples of where this technology has helped me in my day-to-day practice. So the advantage of ultrawide field FAF is that we can image a lot of other findings in the peripheral fundus which are not seen in traditional autofluorescence imaging. So how does a normal autofluorescence map look? So these structures which are black are the optic nerve head, which is due to absence of RPE and lipofuscin, the fovea, which is dark, and all the blood vessels which are dark. And the general fundus will have this kind of isofluorescent grayish kind of appearance. So next we need to know what is abnormal fundus autofluorescence, and that's usually due to the change in the composition of the fluorophores in the RPE. So we need to know only two terminologies. One is hypoautofluorescence, which is the dark areas, and hyperautofluorescence, which is the bright areas. So in short, what dark means is that it means dead. That means dead RPE cells, there's no lipofuscin, so you get a dark signal like this, and sometimes you get it because of blocking or absorption of the light by some other lesions, but in general, black means dead. And examples of these are RPE atrophy, laser scars, hemorrhage causing blocking, exudative lesions. What about hyperautofluorescence? That means brighter areas on the screen, like as seen here. So this is due to excessive accumulation of lipofuscin, and this indicates increased metabolic activity due to sick RPE. So examples are like yellow lesions like pattern dystrophies, some soft drusens, and macular dystrophies. So this is the most important slide. Dark is dead, that is dead RPE, and bright is sick, that is due to increased metabolic activity of the RPE. So let's come to some case examples. So optic disc drusen AF is very, very important in differentiating pseudopapilledema from true papilledema. Now these are two discs which look properly like optic disc edema, but when you do an autofluorescence imaging on these patients, you realize that this is the optic disc drusen light up on autofluorescence, and this is a patient of true papilledema due to a CP angle tumor, and from this you cannot distinguish at all, but you can save this patient from going in for an MRI. Now this is especially true when you have buried optic disc drusen like this. When you have surface drusen like this, where you can see a lumpy appearance, it's, I mean, you know what you're going to get an autofluorescence. What about drug toxicity? So this is a patient whose fundus looks remarkably normal, and the vision is also 6/6. The patient who has been on ICQ for a long period of time, and the autofluorescence shows you a bullseye maculopathy. So there are many drugs which can cause retinal drug toxicity, like HCQ, dynodazine, and thyroidazine. So now this patient has 6/6 vision, but of course this patient is complaining of some distortion in vision, and you can see some RPE changes here. The OCT also shows some degeneration, and the AF shows you very dramatically the presence of bullseye maculopathy due to HCQ toxicity. The challenge is to actually pick up HCQ toxicity at a much earlier stage, so that you can tell the patient to stop the drug. There's another patient who came to us 5 years on tamoxifen, and the fundus just showed very subtle changes. The OCD showed this kind of changes that we thought maybe it could be PFT, till we got the history of tamoxifen usage. And the autofluorescence showed us this hyper autofluorescent lesion at the foveal center, and we could confirm this of tamoxifen toxicity in this patient. What about CSR? In CSR, we get an area of hyper autofluorescence in the area of serous elevation. And very often we have seen this granular kind of hypoautofluorescence. And usually this corresponds to the leak that we see on fluorescent angiography. So in a rare case, when you are not able to do a fluorescent angiography or something, you could use this for doing for the area of micropulse laser, which I do in this area of leak. And autofluorescence also, wide field autofluorescence helps us in demonstrating these RPE tracks, which are a part and parcel of chronic CSR. You can see all these gravitational tracks almost as well as you can see them on fluorescent angiography. It's another patient with chronic CSR and RPE tracks. And you can see how dramatic it is, almost as if you are doing a fluorescent angiography. This is a patient where you can hardly see any tracks clinically, but you can see this, and this confirms the presence of chronic CSR. This is a patient of a BRVO, which has been lasered and had some fluid at the macula. And by doing a AF, we could make out that this patient, the fluid was actually due to the CSR and not due to the BRVO. It's another patient who had been advised anti-VEGF elsewhere, and you could see this yellowish vitelliform kind of lesion, which was actually subretinal fibrin, and the AF showed me chronic CSR cases. It's another patient that was advised who had undergone multiple anti-VEGFs elsewhere, and this was the OCT picture, and AF, wide field AF confirmed the diagnosis of chronic CSR. What about AMD? AMD in ultraviolet field, we get a lot of abnormalities in the periphery, which were in almost 97% of patients, we get abnormalities in the periphery as well. So as we talked about earlier, that dark areas are basically dead RPE and photoreceptors. And in geographic atrophy, what we look for is the zone of hyper autofluorescence around these areas of hypoautofluorescence. And this indicates that these are the areas of future damage that's going to happen and the enlargement of the geographic atrophy. So this has also been classified into different forms, and they have different prognosticating this. It's another patient with geographic atrophy. So you can see the zone of hyperautofluorescence, which indicates the progression of the disease. Now, very often we have patients like this with dry AMD, and they have relatively good vision. And you wonder why they are complaining so much. And that's because when you look at the autofluorescence, you can make out that these are all scotomatous areas. And when the patient says that his vision has gone down, and you see on a follow-up case, you can actually see these dark areas increasing. Now, RPE rip can be very elegantly seen on ultrawide field. This is exactly opposite of what will happen in a fluorescent angiograph. So here you'll get a complete dark area where the RPE is ripped off, and the scrolled up RPE will appear as hyperautofluorescent. It's a patient who complained, a 28-year-old lady who complained of decrease in color vision and day blindness kind of thing. And this was the OCT image. And the ultrawide field showed us like a bullseye maculopathy, suggestive of cone dystrophy. Some other patients of bullseye maculopathy. And very often you see patients with nearly normal looking maculas, where you can pick up these lesions on. There's another patient where you can see that the fundus looks nearly normal, but you can see a hyperautofluorescent here, indicating a maculopathy. This is a classic Best disease. This is in the egg yolk stage and the scrambled egg stage. with the OCTs, and you can see how dramatic the appearance is on autofluorescence. Another patient. Okay, this is pattern dystrophy. This is another case of Best dystrophy. This is another pattern dystrophy. Butterfly shaped pattern dystrophy. Okay, coming to Stargardt's, sometimes you have very early cases where you get this very subtle findings, but you can see some kind of an atrophic lesion here. So when you see the same patient on autofluorescence, you can see this atrophic lesion here showing up as hypoautofluorescence and this zone of hyperautofluorescence. You can also look at these flecks here, which are part and parcel of Stargardt's disease. And if you notice, over a period of time, these flecks have turned black. And these are the, so it's helpful in monitoring of Stargardt's disease, where the active flecks are white and the older flecks, I mean, as time goes by, they turn atrophic. You can also see the zone of hyperautofluorescence increasing here. Hypoautofluorescence, I mean. Coming to retinitis pigmentosa, you can see changes on autofluorescence which are much more dramatic than what we see clinically. So I'll just run through some of these patients of RPE. Sometimes in very, very mild RPs, it's very helpful to do ultra wide field of FAF. Now this is a patient of PPCRA, and you can see it's very elegantly demonstrated here. You can see the atrophy around the veins. This is a very important indication for FAF, that is posterior uveitis. This is a patient of serpiginous choroidopathy. You can see all these healed lesions. You can see some active lesions here, and they show up as hyperautofluorescent lesions here. And the same thing you can see after treatment with steroids. The lesions have the hyperautofluorescence has gone away now. So this is a very elegant method of following up a patient without dilating the patient. Another patient. Then MUDES. Before treatment, after treatment, you can see all these choroiditis lesions here. VKH, you can see, this is literally like doing a fluorescent angiogram. You can see all these areas of exudative RD, and this is post-treatment. Another patient of VKH, pre and post. So another important indication is to, when you see a pigmented lesion like this, is it a choroidal nevus, is it a CHRPE, or is it sometimes a melanoma? So then the choroidal nevus disappears on AF, whereas CHRPE appears hypoautofluorescent. So you can give a definite diagnosis to the patient. And a choroidal melanoma has this kind of hyperautofluorescence granular. So it's the nevus disappears on, so nevus here disappears on AF. This is CHRPE which remains hypoautofluorescent. This is a choroidal melanoma, probably. It's still sent for investigation. You can see this hyperautofluorescence here. So this is the final take home, that black is dead RPE, and that is the blocked signal you can see here, and bright is sick RPE due to increased metabolic activity of the RPE. And the conclusion is that it should be a part of all comprehensive eye exams because non-invasive. It provides information on the metabolic state and overall health of the RPE. It allows the detection of many pathological conditions with peripheral findings, especially when they are, the lesions are not seen clinically.